Usually when we talk about a medical diagnosis, there is this expectation of clinical precision. Like you break your arm, the X-ray shows that jagged white line, and the doctor just points and says, "Yep, there it is."
Right. It is very binary. It is either broken or it is not broken. We really like things to be visible and, neatly categorized.
Yeah, exactly. But then you step into the world of chronic pain conditions, specifically women's health and pelvic pain, and suddenly that X-ray machine is just completely useless. You are looking at a diagnostic landscape that is, well, it's incredibly murky.
Oh, absolutely. It could
Uh-huh.
be incredibly frustrating for everyone involved.
Right. So today we are pulling from a stack of recent clinical dermatological guidelines and urogynecology research papers to look at a reality that affects millions of women worldwide. We're doing a deep dive into chronic vulvovaginal pain.
Yes. And it is such an important topic.
It really is. And more importantly, we are zeroing in on the cutting edge regenerative treatments that are like fundamentally changing how we approach tissue repair. And we're going to answer one highly specific question that basically makes or breaks these procedures.
It really is a profound shift in the literature. Because for decades, the protocols that were offered were mostly just about, managing the discomfort, just applying a topical and sort of hoping for the best.
Yeah, just putting a Band-Aid on it. Right.
Exactly. Rather than actually addressing the underlying cellular health of the tissue itself. So to truly understand how these new injection therapies work
Mm.
and why their post-procedure protocols are notoriously strict, you first have to understand the microscopic ecosystem we're dealing with.
Okay, let's unpack this.
Yeah.
If you are listening to this and you have navigated the pelvic pain space, you probably already know the two major conditions dominating the clinical data.
Right, vulvodynia and provoked vestibulodynia.
Yeah, or PVD, and we aren't talking about like a transient infection here. PVD is highly localized pain, specifically in the vestibule, so the tissue immediately surrounding the vaginal opening.
Yes.
And looking at the epidemiological data, you realize you are looking at roughly 7 to 15% of the female population dealing with this.
It is a staggering number. It really is. And when you look closely at the histology of the tissue in these patients, particularly those dealing with concurrent inflammatory conditions like lichen sclerosis, you see exactly why it hurts.
Right, because the tissue is actually changing physically.
Exactly. Lichen sclerosis is chronic and inflammatory, and it preferentially targets the anogenital region. But microscopically, the tissue architecture is actively collapsing. The collagen fibers in the deeper layers of the dermis, they actually become fused and hyalinized.
Hyalinized, so they kind of turn into this like stiff mass.
Yes, they homogenize into a stiff, non-functional mass. It loses all its normal properties.
Which presents clinically as those pale white patches that are just incredibly fragile and prone to agonizing itching, right?
Exactly. And that triggers the lichenification process, which I think most people know as the itch-scratch cycle.
Oh, right, where you just can't stop.
Yeah, the severe itch forces a mechanical trauma, which is the scratching. And in response to that mechanical trauma, the skin attempts to hypoproliferate to protect itself.
So it gets thicker.
It thickens, yes. But this thickened lichenified skin is entirely dysfunctional because the hyalinized collagen lacks normal elasticity. So the moment that vestibule tissue is subjected to stretching, I mean even minor physiological stretching, it splits and fissures.
Wow. So is this essentially like a microscopic desertification of the skin? Like the tissue loses its moisture, its elasticity, and its structural integrity all at once?
What's fascinating here is that it's the perfect analogy. It is complete desertification. And
Yep.
just like a desert, you are looking at a landscape fundamentally devoid of its essential resources.
It's just entirely dried out.
Right. There is a literal loss of matrix mucopolysaccharides. That is the gel-like ground substance that keeps the extracellular matrix plump and viable. And the elastic fibers are fragmented.
So the whole structure just sort of caves in.
Yeah, so you have this total loss of trophism, of overall tissue vitality. The microscopic shock absorbers are basically gone, which leaves the densely packed nerve endings of the vestibule exposed and, well, hypersensitive to the slightest friction.
Which explains how medicine has traditionally tried to, water this desert. If you've been prescribed treatments for this, you're probably familiar with the gold standard first-line defense.
The high-potency topical corticosteroids.
Right, like Clobazole ointment, alongside a heavy rotation of barrier creams. But if we think about this logically, we know that long-term use of strong steroids actively induces skin atrophy.
Yes, it inhibits collagen synthesis.
Exactly. It physically thins the skin. So if the core problem is already fragile, tearing, desertified tissue, Aren't we risking making a thin skin problem exponentially worse by continually throwing high-potency steroids at it?
You've just hit on the steroid paradox.
This steroid paradox, okay.
Yes, which is heavily debated in dermatological circles.
Right.
It is exactly why these clinical guidelines stress that steroids are not a long-term regenerative solution. The primary goal of the clobetasol is strictly to act as a chemical fire extinguisher.
A fire extinguisher, I like that.
Right, because you have a raging, localized, autoimmune-like inflammation destroying the tissue. The steroid suppresses that localized immune response. It puts the fire out. But, putting out the fire doesn't rebuild the house.
Yeah, and if you leave the fire extinguisher running too long, the chemicals just start eating through the floorboards.
Precisely. Unmonitored, prolonged steroid use on non-keratinized or thinly keratinized mucosal tissue, it will lead to profound iatrogenic atrophy. You have to extinguish the acute flare-up, taper off, and then immediately pivot to defending whatever structural integrity is actually left.
And I guess that's where the barrier creams come into play. But there is a really crucial distinction in the literature between hydrating moisturizers and true occlusive barriers, right?
A very big distinction, yes.
Because if you're dealing with PVD or microfissures, an everyday moisturizer that just absorbs into the skin isn't really doing the heavy lifting. You need something that acts as a physical winter coat for the vulva.
The winter coat is actually the perfect way to visualize true occlusion, because the vulvar vestibule is subjected to relentless environmental stressors.
Like friction from walking, sweat, that kind of thing.
Friction, sweat, and crucially, the osmotic and chemical stress of urine. Urine is highly caustic to an open microfissure.
Oh, ouch. Yeah, that makes sense.
Right, so a true barrier ointment, utilizing something chemically inert like zinc oxide or high-grade petrolatum, it doesn't absorb. It just sits right on top of the stratum corneum, creating this hydrophobic shield.
So it literally seals the micro tears off from the environment.
Exactly, allowing the endogenous healing cascade to occur without being constantly reset by, chemical burns from urine.
So what does this all mean? It means the winter coat and the fire extinguisher are great for managing the environment. But for patients where the pain is really entrenched and the tissue architecture is already hyalinized, managing the environment just isn't enough.
No, the tissue cannot repair itself on its own at that stage.
And that is where we see urogynecology turning to direct cellular interventions to physically reconstruct that desert.
Yes, this is where we cross from symptom management into regenerative medicine. The research papers we are looking at focus heavily on two specific injectable protocols: platelet-rich plasma, commonly known as the O-shot, and HCC injections.
And HEC utilizes thermal stabilized hyaluronic acid and polynucleotides, right?
That's correct. We are moving beyond occlusion and actively forcing the tissue to rebuild its extracellular matrix.
Okay, let's get into the biological mechanisms of PRP first, because it's genuinely fascinating. It's an autologous treatment, meaning the raw materials come directly from your own venous blood.
All right.
But we aren't just injecting whole blood back into the tissue.
Oh no, whole blood would be highly inflammatory. You draw the blood, and you centrifuge it to separate the plasma and the cellular components. The target here is the platelets.
Ah, the platelets.
Yes, when concentrated and injected into the compromised tissue of the vestibule, these platelets undergo degranulation. They physically open up and release their alpha granules, which contain just a massive concentration of growth factors.
And the most critical one is VEGF, right?
Yeah.
Vascular endothelial growth factor.
Exactly. VEGF is the primary signaling protein that promotes angiogenesis, or, neovascularization.
Making new blood vessels.
Right. When VEGF is released into that desertified, hyalinized tissue, it binds to receptors on the nearby endothelial cells. This triggers those cells to proliferate and migrate, literally sprouting new capillary networks. You are building new blood vessels from scratch.
That is wild. And increased vascularity means higher oxygen perfusion, better nutrient delivery, and I guess a restoration of that lost trophism. Which brings us to the other major player in the recent literature, HCC injections. And if you're thinking of the hyaluronic acid in your daily skincare routine, you need to throw that image right out.
Yes, completely different application.
We aren't talking about a topical serum sitting on the epidermis. We're talking about deep intradermal injections delivered via highly specific micro-punctures, using ultrafine 29-gauge or 30-gauge needles going directly into the submucosal layer of the vestibule.
The distinction is vital. Topical hyaluronic acid provides transient surface hydration, but injected HCC is an entirely different mechanism. HCC stands for a hybrid cooperative complex. It's thermal stabilized hyaluronic acid.
Okay, thermal stabilize, why does it matter?
Well, if you inject standard non-cross-linked hyaluronic acid into the body, an enzyme called hyaluronidase will degrade it and flush it out within maybe 24 to 48 hours. It's useless for long-term repair.
Oh, I see. But usually to stop that degradation, aesthetic fillers use chemical cross-linking agents, right? Like BDDE, which can trigger their own inflammatory issues.
Right, and what's fascinating here is how the thermal stabilization bypasses that completely. By using highly controlled heat processes, they force high molecular weight and low molecular weight hyaluronic acid to physically interlock.
Without adding the toxic chemical cross-linkers.
Exactly. And when this thermally stabilized complex is injected into the vestibule, it resists enzymatic breakdown for weeks.
Okay, here's where it gets really interesting. Because it sits there for weeks, it's not just acting like a sponge for water, it acts as a physical scaffold. It restores the mechanical tension of the tissue, which physically stretches the dormant fibroblasts.
Yes, the mechanical stretch is key.
And when those fibroblasts feel that stretch, they wake up and start synthesizing fresh endogenous type I and type 3 collagen. We are basically taking the raw construction materials, walking them past the broken front door, and dropping them deep into the extracellular matrix to force a rebuild from the inside out.
If we connect this to the bigger picture, you are seeing a literal reversal of that desertification process we discussed earlier. The PRP is rebuilding the irrigation system, the blood vessels, and the HCC is rebuilding the soil, the collagen and elastin matrix.
It's amazing.
It is, but as you can imagine, delivering these materials requires traversing some incredibly hostile terrain.
To put it mildly, I mean, the vulvar vestibule is one of the most densely innervated structures in the human body.
Yes.
If you have PCD, those nerve endings are already upregulated. They are hyper-excitable. You cannot just take a 30-gauge needle and start delivering dozens of punctures without serious pharmacological intervention first.
Absolutely not. The protocols mandate rigorous pre-procedure anesthesia. The standard approach detailed in the clinical guidelines involves the application of a topical eutectic mixture. EMLA cream is the classic example. It's a specific ratio of lidocaine and prelocaine.
And the eutectic part is the key to why it actually works on mucosal tissue, right?
Exactly. When you mix lidocaine and prelocaine base powders in a 1-to-1 ratio, their combined melting point actually drops significantly below room temperature.
Wait, so they turn into a liquid?
Yes, they form a liquid oil, and this allows for a much higher concentration of the active anesthetics to be suspended in the cream's water droplets. Because it's highly concentrated and lipophilic, it can rapidly penetrate the non-keratinized epithelium of the vestibule and block the sodium channels in those hyperexcitable nerve endings.
Wow.
Often they'll leave this on for 30 to 45 minutes, sometimes even followed by an injectable nerve block, just to make the actual micro-injections tolerable.
Which brings us to the absolute core focus of today's deep dive. The injections are done, the neocollagenesis and angiogenesis have been triggered, but the numbing cream is about to wear off.
And that is a very critical moment.
Right, because you are now left with a highly innervated, severely compromised vestibule suffering from acute localized edema swelling. And it's dotted with dozens of fresh micropuncture tracks. And that begs the critical question. What post-procedure barrier emollient is strictly recommended to soothe these micropuncture sites immediately after the injection?
This acute post-procedure window is where everything can go wrong if the aftercare protocol is ignored.
Really? Everything?
Yes. Those micropuncture tracks are literally open doors to the deep dermis. The natural barrier function of the skin has been intentionally bypassed. If a chemical, irritant, or even just urine enters those tracks, it will trigger an aggressive inflammatory response.
And I assume that ruins the treatment.
It can completely short-circuit the regenerative signaling we just worked so hard to initiate.
Yikes. So looking at the dermatological guidelines, there are very specific recommendations for this window. One of the primary targeted options cited is Lavure Advanced Post-Procedure Skin Barrier Gel.
Yes, a Lavure is often recommended.
And this isn't just a generic lotion. It's formulated specifically for compromised, punctured skin following aesthetic and dermatologic interventions. It's designed to provide a breathable, protective film, giving you that essential occlusion against external irritants, while maintaining an optimal moisture gradient so the puncture sites can close.
Lavure is an excellent clinically validated option for this specific scenario. But the guidelines also heavily emphasize that, fundamentally, Pure chemically inert barrier ointments are the gold standard. We're talking about pure white petrolatum or zinc oxide formulations.
Like Vaseline or Desitin?
Exactly. The reason these are mandated is their sheer chemical simplicity. White petrolatum is biologically inert. It does not react with the tissue at all. It simply sits on top of the micropunctures, forming an impenetrable hydrophobic shield.
The ultimate winter coat.
It is the ultimate manifestation of the winter coat deployed at the exact moment the tissue is most vulnerable.
But the clinical literature is equally, if not more, aggressive about what you absolutely must avoid putting on these micropunctures. Because if you're in pain as the numbing cream wears off, this is where it's so easy to make a catastrophic mistake by reaching for an over-the-counter anti-itch cream.
Oh, absolutely. That happens too often.
Yeah, the guidelines explicitly forbid the use of products containing propylene glycol, fragrances, or sensitizing topical anesthetics like benzocaine or diphenhydramine.
Applying any of those agents to fresh micropunctures is a recipe for iatrogenic disaster. Let's look at propylene glycol, for example.
Okay.
It's a very common humectant and solvent in everyday cosmetics, but when introduced into a deep open micro wound, it acts as a penetration enhancer and causes severe osmotic stress to the newly forming cells.
Wow, so it actually damages the cells we want to heal.
Yes, it is directly cytotoxic to the exact cellular repair mechanisms we are trying to encourage.
And the over-the-counter anesthetics are even worse. If the EMLA is wearing off and it stings, reaching for a drugstore benzocaine cream seems super logical, but apparently it triggers a massive immune reaction.
Benzocaine and diphenhydramine are very potent sensitizers. When you apply them to intact skin, the risk of an allergic reaction is, moderate. But when you drive them deep into the dermis through micropuncture tracts, you are completely bypassing the skin's immune defenses.
So it goes straight into the bloodstream.
Essentially into the deep tissue, yes.
Yeah.
You frequently trigger a type 5e delayed hypersensitivity reaction, which is allergic contact dermatitis. Your immune system, which is already on high alert from the microtrauma of the needle, identifies the benzocaine as a severe threat and launches a massive inflammatory attack.
Oh, no.
You end up with blistering, severe erythema, and agonizing pain, completely negating the regenerative benefits of the PRP or HCC. You must stick to inert occlusive barriers like the Lavior gel or white petrolatum.
And there is a highly functional mechanical reason why that specific type of friction-reducing barrier is mandated. It's not just about keeping urine out.
No, it's not.
If you look at the specific protocol for HCC injections, the procedure doesn't actually end when the needle comes out. The physician is required to perform an immediate, vigorous manual massage of the vestibule, and the patient is instructed to continue this targeted massage at home over the next 3 days.
Yes, the hyaluronic acid complex is cohesive, but it needs to be uniformly distributed throughout the tissue matrix. To prevent it from pooling into localized nodules, you have to physically spread the scaffold.
But imagine trying to deeply massage a highly innervated, acutely swollen vestibule that is covered in micropunctures. I mean, without optimal glide, the mechanical shear force alone would be
It
agonizing.
would be unbearable and would further traumatize the tissue.
So the thick, inert emollient like the white petrolatum or the Lavior gel is a strict functional requirement. It provides the necessary slip to execute the post-care massage, ensuring the HCC integrates smoothly into the surrounding tissue while simultaneously sealing the puncture tracts from contamination. It's just a brilliant dual-purpose shield.
Exactly. It creates the precise, isolated environment the body needs to execute the complex biological cascades we triggered.
It's just incredible to see how meticulously engineered this entire process is, from the macro down to the cellular level. I mean, we started this deep dive looking at a landscape of chronic pain, the hyalinized collagen, the loss of matrix mucopolysaccharides, the brutal feedback loop of the itch-scratch cycle in conditions like lichen sclerosus and PVD.
Right. And we saw the limitations of just putting out the fire with steroids and the vital role of the winter coat occlusion.
Which naturally led us to the regenerative frontier, taking the body's own platelets to release VEGF and stimulate angiogenesis, or deploying thermally stabilized hyaluronic acid complexes to mechanically awaken dormant fibroblasts.
It's truly revolutionary.
And finally, we answered our core clinical question protecting that investment, the absolute necessity of utilizing chemically inert, breathable barriers, like Lavior Advanced Post-Procedure Skin Barrier Gel or Pure White Petrolatum immediately post-procedure, blocking out caustic irritants, avoiding cytotoxic solvents like propylene glycol, and providing the functional glide needed to massage the tissue without triggering contact dermatitis.
This raises an important question, though.
Yeah.
When you look at the sheer biological complexity of what is happening in the vestibule of these patients, the structural collapse of the extracellular matrix, the localized neuroproliferation, it forces a broader reckoning. For decades, women presenting with localized pelvic pain were routinely dismissed.
Yeah, told it was all in their heads.
Exactly. They were told the pain was psychogenic, a manifestation of anxiety or stress. But now we are physically viewing the degraded collagen under a microscope, and we are treating it by physically rebuilding the tissue's vascular network from scratch.
It's undeniably profoundly physical.
It forces us to ask, how many other chronic pain syndromes in the human body are currently being dismissed as in our heads, simply because our diagnostic imaging tools haven't yet looked closely enough at the microscopic architecture of the tissue. If the collapse of microscopic ground substance can cause this much localized agony in the vestibule, what are we missing in other joints, other mucosal tissues, other nerve plexuses?
Wow. That is a lot to think about. We started this deep dive talking about how much we crave the simplicity of a broken bone on an x-ray and how much we hate the murky waters of invisible pain. But looking at the histology, maybe the waters were never actually murky. Maybe we were just stubbornly refusing to use a better microscope.
Thank you for joining us on this deep dive. Stay curious and keep seeking out the cellular why behind the information.